actions of the most commonly used antiepileptic drugs in dogs and cats. To start with, we'll go over the action potential, as the mechanism by which most antiepileptic drugs work is by altering the action potential. When discussing the action potential, we generally focus on the axon and the synapses. And so first, we'll start off by going over what's going on at the level of the axon and just recall some key points. Remember that relative to one another, the outside of the cell is going to be more positive than the inside of the cell. And if you were to measure the difference between the two, it would read approximately negative 70 millivolts. So here we have an axon, and in blue is the myelin, and all along the axon are different ion channels, but the ones that we will focus on are at the nodes of Ranvier, where I've drawn the sodium and potassium channels, and then there's also the sodium-potassium ATPase pump. Obviously, there's more than 3 of these channels or pumps at each of these nodes, but again, this is just for representation purposes. So when an action potential occurs, there's going to be an opening of the sodium channels, and the sodium will flow into the cell, and this will cause a rise in the voltage within the cell itself. The inactivation gate will then close on the sodium channel, and eventually the slower voltage gated potassium channels will open, allowing potassium to flow out of the cell, which will bring the voltage back to a negative value closer to negative 90 millivolts. Again, when the potassium channels are open. And there's not going to be any flow of the sodium at this point because of the inactivation gate that has closed. With the outflux of potassium, eventually the voltage will go back to the resting membrane potential at approximately negative 70 millivolts, leading to closure of the sodium and potassium channels. The inactivation gate will return to its normal position, and the sodium-potassium ATPase pump will return the potassium into the cell and the sodium outside of the cell. At this point, the axon is again ready for the next action potential. And looking at the image on the upper right, you can see that this all occurs in less than 5 milliseconds, it's always impressive to me to think about how quickly that happens. So that's what occurs at the level of the axon. And again, that's occurring at all the nodes of Ranvier. When we're talking about the endpoint of the action potential, now we're looking at the axon terminal. Now there are some key players to talk about. Some of these key players that we need to know are the cytoskeleton. There's the vesicle itself, which contains a neurotransmitter, which for this example is going to be the excitatory neurotransmitter glutamate. There's what's known as synapsin, which attaches the vesicle to the cytoskeleton. There's the RAB2A GTP complex, which will serve as a chaperone eventually. There's what's known as calmodulin, which is an intermediate calcium binding messenger protein. There's another substance called CAMK2, which is a specific kinase regulated by calmodulin, and it serves as part of a signaling cascade. And then there's also what are called snare proteins, which we'll discuss in more detail later on. And then there's also the calcium channels, which are the final channels within the terminal. So when an action potential occurs, the saltatory conduction is possible because of the voltage-gated sodium channels, but the end result of the action potential is opening of the calcium channels. Now, one of the actions of calcium when it enters into the cell is to bind to calmodulin. This will then activate CAMK2, whose job is ultimately to phosphorylate synapsin. Once phosphorylated, the vesicle will detach from the cytoskeleton and bind to the RAB2A GTP complex. The RAB2A GTP complex will serve as a chaperone to bring the vesicle down to the snare proteins, at which point the vesicle is docked at the axon terminal. The main vesicular snare or V-snare proteins that we'll be concerned about is synaptobrevin, and then for the T-snare or the terminal snare proteins are syntaxin and SNAP25. After docking, a vesicular protein known as synaptotagmin can bind with calcium. This will then cause a conformational change to where the vesicular membrane will fuse with the axonal terminal membrane. And once fused with the terminal, the neurotransmitter will then be released into the synapse to bind to the postsynaptic receptor. Now, the reason for going through all this is because when we talk about the causes of seizures within our actual lecture and then ways to treat seizures, it's helpful to have an understanding of what is occurring at the cellular level. One last thing we'll talk about is the Goldman equation. So going back over the action potential, recall that it is an all or none phenomenon. and that the resting membrane potential sits somewhere around negative 70 millivolts for neurons. The way to calculate the resting membrane potential is by what is known as the Goldman equation. Now, the Goldman equation takes into account the Nernst potential, or the equilibrium in millivolts for each ion. And so the ions that are used in the calculation of the Goldman equation is going to be sodium, which the Nernst potential for sodium is positive 55 millivolts. For chloride, it's around negative 65 millivolts, and for potassium, it's around negative 90 millivolts. This is important to understand as we look at the mechanism of actions of the antiepileptic drugs. So we'll first start out by talking about some of the long-acting antiepileptic drugs. And this here is a list of the most common antiepileptic drugs used in veterinary medicine. The first one we'll talk about is phenobarbital, and it is part of the drug class known as barbiturates. So the way that barbiturates work is at lower dosages, they will bind to GABA-A receptors. So GABA is an inhibitory neurotransmitter, and when it binds to GABA-A receptors, it's going to open chloride channels. And if you look back at the Goldman equation, you'll see that chloride, Nernst potential, is around negative 65 millivolts, which sits just above the resting membrane potential. However, recalling back to the all or none phenomenon, if you have more chloride channels open, it's going to make it harder to reach threshold, which for that all or none phenomenon to occur, threshold is around negative 55 millivolts. So if you have more chloride channels open, there's going to be failed initiation for the action potential, meaning it's going to make it more difficult to reach threshold, and therefore the action potential will not occur if these chloride channels are open. The way that barbiturates work is by binding to GABA-A receptors to prolong the effects of GABA. Now, at higher dosages, barbiturates can actually activate the GABA-A channels without GABA being present. And they can also inhibit glutamate NMDA receptors to prevent excitation of the postsynaptic neuron. The effect on activation of GABA-A channels and the inhibition of glutamate is why barbiturates have a narrow window of safety compared to a lot of other antiepileptic drugs, and why they can also be used for euthanasia. The next drug that we will discuss is called imepitoin, which most of you are not going to be familiar with. Now, imepitoin has a novel and selective mechanism of action that potentiates GABAergic inhibition by acting as a low-affinity, low-efficacy partial agonist on the benzodiazepine site of the GABA-A receptor, which increases the affinity of GABA to GABA-A receptors. Now, we will discuss benzodiazepines later, but with imepitoin, although it differs in chemical structure from benzodiazepines, because of its low affinity, if a benzodiazepine is given, it will disassociate the imepitoin from its binding site. Now, in the cases that we'll go over during the lecture, we will discuss some side effects of the medications, but because imepitoin is not one that's available here in the United States yet, we're not going to be discussing it in the cases. So just so you're familiar with it, how it's used, dosages, side effects, I'm just going to go over some of that information with you now. The reason why you've probably never heard of this medication is because it is a veterinary-only medication. And the only way that it can be put on the market and licensed by the FDA is for imepitoin to be put against an FDA-approved medication, which for dogs, when we're talking about epilepsy, is going to be primidone. This is the only FDA-approved antiepileptic drug in veterinary medicine, but nobody is going to do a study to compare imepitoin to primidone because they don't want to put a lot of dogs into liver failure. You can look up primidone studies if you want on your own time, but nobody uses it anymore because it's not a safe drug. But this is the reason why imepitoin is not available here in the United States yet. So to get around this, the people who have created imepitoin have found that it is useful for fear and anxiety related problems in dogs. And so when it's finally licensed here in the United States, it's going to be licensed for dogs with anxiety rather than for using it as an antiepileptic drug. Most people will use it as an antiepileptic drug, but it's going to be used off-label. As far as using it for fear and anxiety, it does seem to significantly improve the anxiety in patients as soon as the first week, with the peak improvement seen about 11 weeks after starting the medication. And most owners within this study chose to continue to use imepitoin at their own expense because they were happy with the results. when imepatone was used for fear and anxiety related problems. As far as using it for seizures, there's a lot of information available from Europe because they've been using it there for years. The information we have on it is that there's no observed long-term adverse events when used at 3 times the recommended dose, and this includes histologically when samples are taken of the liver and kidneys. As far as how well it actually works, if you're looking at reduction of greater than or equal to 50% in monthly seizure frequency, comparing it to phenobarbital, about 75% of patients responded to imepatone compared to 83% of patients on phenobarbital. So it doesn't appear as effective as phenobarbital. However, it's pretty close and seems to be better than any other drug that we have, again, other than phenobarbital. The one thing that we don't have much information is dogs that have cluster seizures or status epilepticus, how helpful is it in those patients? But what we are starting to find out with imepatone is that the older a dog is when they start having seizures, the more likely it is that imepatone is going to help that patient. So as a general rule, if a patient is less than 2 years of age when they start having seizures, if it's related to idiopathic epilepsy, those patients are better off on phenobarbital. If they're over 2 or 3 years of age when they start having seizures, it seems that the majority of those patients will respond positively to imepatone. As far as the pharmacokinetics, the half-life is around 2 to 6 hours. Although, even though it has a short half-life, it's still only given twice a day. It is metabolized by the liver, but it can be excreted mainly within the feces. And neither reduction in kidney or liver function is likely to influence the pharmacokinetics of imepatone. So it seems to be safe in patients even if they have liver or kidney impairment. As far as interactions and adverse reactions, looking at it long term, there's no information on pharmacokinetic interactions between imepatone and other medications other than benzodiazepines. Again, benzodiazepines have an increased affinity for the benzodiazepine binding site on the GABA A receptor. And so if you give a benzodiazepine, the effects of imepatone are negated. So if you have a patient that's on, say, a diazepam CRI, you're going to have to give them a medication like Keppra or phenobarbital until they're off that CRI and can take imepatone orally again. Now, because imepatone has such a short half-life, it will be effective pretty quickly, even after just a single dose of imepatone. So you don't have to worry about loading them afterwards. The dose of imepatone is 10 to 30 milligrams per kilogram every 12 hours, with most papers recommending giving it between 20 and 30 mg per kg. As far as short-term side effects, there can be PUPD, polyphagia, ataxia, vomiting, diarrhea, and sensitivity to sight and sound. However, it seems that after a week, no observable side effects have been documented. So that's the information I have on imepatone. Again, it's still not available here in the United States, but hopefully in the near future. It was supposed to be here this year, but because of coronavirus, things have been delayed. So potentially by next year, we might be using it here in the United States. The next drug we will discuss is potassium bromide. So going back to our periodic table of elements, recall that the first column of elements are going to be called alkali metals. The last column are your noble gases, which are the most stable elements. And then the column in red are your halogens. You might have heard the term halogen before because of halogen lights. And the reason for them being called this is because halogen lights contain one of the halogens, usually iodide. But the halogens are very attracted to the alkali metals because the halogens just need one more electron in their outer shell, whereas the alkali metals have only one electron in their outer shell. And when you combine a halogen with an alkali metal, you create a salt. So when you combine sodium and chloride, it will give you what we typically think of with table salt. And when you combine potassium and bromide, then it gives you the salt that we think of as the medication potassium bromide. Now, there's a lot of theories as to why potassium bromide helps control seizures, and the general thought is because of the association between bromide and chloride both being halogens. But it's a little bit more complicated than just that. Well, it goes back to the GABA A channel again. So recall that when GABA binds to GABA A, it's going to open these chloride channels. And so chloride's normally going to flow into the cell when those chloride channels are open. But bromide actually has a higher affinity to flow through these GABA channels. And the end result, as far as bromide flowing into the cell, is going to be the same as chloride flowing into it. So it's going to be more difficult for that cell to reach its action potential, that negative 55 millivolt threshold. Now, because bromide has an increased affinity for the GABA A channel, if you have a medication, such as a barbiturate, that prolongs the effect of GABA, you can actually have synergistic effects when these two medications are given together. So a lot of patients that are on both of these medications are on lower dosages of the medications because of the synergistic effects that can happen. The next drug I'll talk about is zonisamide. So let's recall the action potential within the axon. So when an action potential occurs, it's going to open the sodium channels, and sodium is going to flow into the cell. The slow voltage potassium channels will then open, and potassium will flow out of the cell. And then the inactivation gate on the sodium channel will close. And eventually the resting membrane potential is restored. And another action potential can then occur. But as you can see in the animation, zonisamide will bind to the sodium channel in such a way that it delays the inactivation gate from reopening. So if another action potential occurs within a short period of time, the sodium will not be able to enter the cell because that inactivation gate is still blocking the sodium channel. Thus, the action potential will cease to propagate. So that's thought to be the main way that zonisamide works. It does have another function in that it binds to the postsynaptic T-type calcium channels, where it makes opening of those channels more difficult. But this is thought to be a more mild effect of how zonisamide works. Zonisamide does have a sister drug called topiramate, which functions similarly to zonisamide, but the biggest difference between the two is it binds to the L-type presynaptic calcium channels instead of the postsynaptic T-type calcium channels. As far as the safety and side effects of topiramate and zonisamide, they are quite similar. Topiramate in people is mainly used as migraine prevention, but it does show some anti-epileptic effects as well. Zonisamide and topiramate can sometimes be used for pain modulation, especially with chronic neuropathic pain. And it's thought to be helpful in that because of the effects on these pre- and postsynaptic calcium channels. The next anti-epileptic drug that we'll discuss is levetiracetam, or Keppra. On the screen, it'll continue to say levetiracetam, but I'm just going to say Keppra because it's easier to say. So if you recall back to the action potential, down at the axon terminal, once calcium enters to the cell, one of the things that it can do is bind to synaptotagmin. From here, it causes fusion of the vesicle to the axon terminal and eventually release of the neurotransmitter. Another vesicular receptor that I have not discussed is called SV2A. Now, SV2A's function is unknown, but we do know that Keppra binds to the SV2A receptor. And this changes the affinity of calcium to synaptotagmin. That's thought to be the main way that Keppra works. Again, binding to that SV2A receptor, which changes the affinity of calcium to synaptotagmin. It also binds to presynaptic N-calcium channels, but the overall effect of this is minimal for inhibiting the calcium channels. This is a different type of presynaptic calcium channel than where topiramate binds. Again, topiramate binds to the L-type presynaptic calcium channels, which I've not shown here in this depiction. The last drug that we'll talk about as far as the long-term anti-epileptics is going to be gabapentin. Gabapentin is not used very much for seizure control, but it is frequently used for neuropathic pain and for sedation in cats, and sometimes we'll use it for seizure control, which is why I'll mention it here. Gabapentin has a couple mechanism of actions. Firstly, it binds to the alpha-2 delta-1 subunit in both the N and the L-type presynaptic calcium channels. So both the calcium channels that Keppra and topiramate bind within the central nervous system, but it does not seem to have a strong effect within the central nervous system. Rather, it has more of an effect on the dorsal root ganglion for controlling pain. Once bound to the presynaptic calcium channels, the end result is a downregulation of these calcium channels rather than inhibiting their function as far as opening. So that's why it has why it takes so long for gabapentin to have its long-term effect, is because it's not inhibiting these calcium channels from functioning, it just ultimately leads to a downregulation of them. Another effect that gabapentin has, as the name implies, is functioning somewhat like GABA. Now, it doesn't bind to the GABA-A receptor, rather, it has an effect on how GABA is broken down. Now, normally, after GABA is released into the synapse, it will bind to the GABA receptor and then dissociate, and it's going to be broken down by GABA transaminase. Gabapentin is different enough in its conformation that it does not bind to the GABA-A receptor, but it will bind to GABA transaminase. Once bound, the GABA transaminase is not able to break down GABA within the synapse, allowing for longer duration of GABA to interact with receptors, and there can also be a buildup of GABA as well. This is why it can be used for sedation in cats, because this effect is going to be more immediate, and potentially this could have some seizure control effect as well. Now, the last two drugs that we'll talk about are going to be your benzodiazepines and propofol. We're not going to go over much, just again, the mechanism of actions. And these are going to be your fast-acting antiepileptic drugs. So we'll first start out by talking about benzodiazepines. And their mechanism of action is going to be through the GABA-A channels again. And as discussed earlier, these bind to the benzodiazepine receptor within the GABA-A channels, not the barbiturate receptor. Barbiturates, again, prolong the duration of action of GABA once it's bound to GABA-A, whereas benzodiazepines increase the affinity of GABA to GABA-A channels. One of the reasons why benzodiazepines work so quickly at controlling seizure is because they're one of the drugs that go to high blood flow, low volume organs first, which that's going to be the brain. And they're also extremely lipophilic. So once the benzodiazepines bind to the GABA-A channel, it again increases the affinity of GABA to those GABA-A channels, and it allows more chloride to enter into the cell. This, again, is a different receptor site than where the barbiturates are going to bind. Propofol works differently than either benzodiazepines or barbiturates in that it does bind to the GABA-A channel, but it makes it harder for GABA to dissociate from the GABA-A channel. It also inhibits the release of excitatory neurotransmitters such as glutamate. And due to the effects on glutamate, that's one of the reasons why its window of safety is going to be more narrow than than benzodiazepines, so something like diazepam. So that was a review on the mechanism of actions on the antiepileptic drugs. Please let me know if you have any questions. I hope you found this helpful, and I will see you in the clinic.